I am using Ibrutinib with rituximab in patients with mantle cell lymphoma with proliferation index, a low proliferation index. And this was based on data from Michael Wan from MD Anderson, in which he shows that the addition of rituximab to Ibrutinib increased overall response rate, CR rate, but again, in this specific population with a low proliferation index. I might need to revisit that based on again, we cannot extrapolate data from one disease to the other, but so there is now clear indication that in chronic lymphocytic leukemia, the addition of rituximab doesn't add to the effect of ibrutinib. In other words, ibrutinib alone seems to be enough to induce good responses in CLL. So I might revisit my use of ibrutinib combination with rituximab in patients with mantle cell lymphomas. But that's probably the only scenario in which I use ibrutinib with other agents outside of clinical trials.
Rituximab is my favorite agent to use with ibrutinib. If you talk to insurers, they'll tell me that's off-label, though there's good phase 2 data to support the addition of rituximab to ibrutinib. In terms of other agents like lenalidomide or chemotherapy, no. I don't routinely give those agents in combination. I haven't found a clear benefit for doing so. I think the data with ibrutinib and venetoclax are perhaps the strongest data, but at least in my practice, it's not something I'm going to do for most of my patients unless they come in with very, more in the way of high-risk disease, so more proliferative, or again, these BRCA3, TRAF2, non-canonical NF-kappa B mutations, where we're expecting we may see a little bit less in the way of sensitivity to ibrutinib. But again, the real challenge is, excuse me, again, the real challenge is how do we get the drug? We have to get these paid for, meaning, patients aren't going to be able to easily pay for both ibrutinib and venetoclax. And it sounds simple, well, just get the insurance approval, do the appeal, get insurance to, review the insurance, medical directors to review the literature, after a peer-to-peer review. And yes, you can do that, but don't forget that ibrutinib alone can come with as high as a $5,000 copay for some patients. There are foundations that can help with that, but now if we're talking about ibrutinib and venetoclax, we're talking about some pretty significant copays for some of our patients, and off of a study, it can be hard to do. Now, one of the nice things is we will see in ibrutinib, there is an ongoing ibrutinib venetoclax randomized trial that will help patients get access to this particular combination.